network. All right, guys. So let me introduce myself. I am Z. My full name's Wei Zito. I'm a GP working in Harlow. I came into the UK in 2016, did the Plab exam then, continued my journey in obstetrics and gynecology for another year. After that, I switched into GP training, and I've completed that as well. And throughout that, I have been running Plabable. Adam has been involved in this, and he's been helping me so much. The team is huge. We've been working so hard on trying to make a platform which is affordable for everybody to use. So that's me. Now I'm going to let Adam introduce himself.
Yeah, I'm Adam. So I have a lot of experience with teaching. I'm an obstetrics and gynecology registrar, having been a previous medical registrar. I helped develop and build the course that we're very proud of, as well as the revision webinars. And we're really excited to share this free webinar with you today, where we just introduce a little bit about how passionate we are about the Plab exam, about educating everyone who's sitting the Plab exam, and just making revision more fun, more sociable. Yeah, and as you can see, we've got our Plabable t-shirts on.
That's right.
Oh yeah, oh, it's no expense spared here. Team Plabable. Okay, so let's get started.
So the Plab exam consists of 180 questions. I'm sure you guys are all aware of this. So that typically means that we would be using about a minute to answer a question. And what we are going to be doing today is run through questions similar to the exam, where you would take a minute to answer, and we want you to put down your answers on the chat, and then we will go through the entire question and discuss what we think is the right answer. So starting off with this one.
Yeah, lovely. Enzyme inducers and inhibitors. So you need to know this. So answer in the Telegram group or in the chat. What do you think it is? A, B, C, D, or E? Keep the answers coming. So you need to know your enzyme inducers and your enzyme inhibitors. Yeah, and this one's specifically asking you about enzyme inducers, and the correct answer is D, carbamazepine. Yeah. Now, enzyme inducers will stimulate cytochrome P450, speed up the metabolism of certain drugs. Okay, so if we go to the next slide, you'll see that I've highlighted the most ones you need to be aware of. Rifampicin, carbamazepine, chronic alcohol use, and phenytoin. You must know these before going into the exam. And you remember it by crap GPs, rubbish GPs, because only a rubbish crap GP would start a woman who's taking an enzyme inducer on the combined oral contraceptive pill. Because what that does is speed up the metabolism of the estrogen component, and the woman ovulates, which is not a very good form of contraception if you're ovulating. And so that, in my mind, is a crap GP. Yeah, super important to know. Enzyme inducers are the same drugs that if you are on warfarin and you're on an enzyme inducer, that will speed up the metabolism of warfarin and therefore lead to a lower INR. Yeah, because there's less active component of warfarin in the serum. As with enzyme inducers, you also have enzyme inhibitors, which slow down the metabolism of certain drugs. And so the next slide, you will see enzyme inhibitors. Yeah, and I've highlighted the most essential ones you need to be aware of. Now, unfortunately, I haven't got a great mnemonic. Sickfaces.com is difficult to remember, but sodium valproate, isoniazid, ketoconazole, fluconazole, metronidazole, ciprofloxacin all slow down the metabolism of certain drugs through the cytochrome P450 pathway. And therefore, if you're on warfarin, you'll have a raised INR because there's more warfarin to antagonize vitamin K. So moving on to the next slide, When I talk about enzyme inducers and enzyme inhibitors, you must always think about tuberculosis treatment, because there's plenty of stuff to talk about here. When you're treating active TB, remember you're going to give all 4 of these drugs for the first 2 months, and we use the mnemonic RIPE. Rifampicin, isoniazid, pyrazinamide, ethambutol. And actually, people coming to our webinar actually feel that that's sometimes the first time they've heard them said out loud. So rifampicin, you need to be aware of what are the specific side effects of rifampicin. So if I ask the group, what is a side effect of rifampicin, you're going to tell me on the group that the side effects are, and this is where there's a bit of silence, but I'm hoping people are considering, thinking about it, got some colorful things being mentioned. Yes, you get discoloration of your secretions, so saliva, tears, urine, sweat will become orange-red. It's hepatotoxic. And remember, we've already mentioned it's the R in CRAP GPs, so it's an enzyme inducer. Isoniazid, so that is associated with peripheral neuropathy. Yeah, so we're going to give pyridoxine, which is vitamin B6, to reduce the risk of peripheral neuropathy. Pyrazinamide, that causes acute gout. And ethambutol can cause optic neuritis, yeah? So it is, it's important that you check the red color vision. So in using an Ishihara color plate to assess red color vision and visual acuity is important for ethambutol. Next slide. So next question. Zee's going to take this one away.
Absolutely, guys. So take a minute to answer this. Amazing. So most of you got that right. Now you're going to be administering midazolam and morphine subcutaneously. This is very important to learn. Now, Adam and I know that, when you come from abroad, palliative medicine is not practiced as well as, in the United States and United Kingdom or Australia or Europe in general. But the fact is, in someone that is dying, you need to realize that he is dying, and your main goal isn't to prolong his life, isn't to shorten his life, is to make him comfortable. And that's palliative care. This patient is end of life already, all right? He's got rectal carcinoma. He's not going to be around longer. Even if you pumped everything into him, you probably save him for another day or two, and he will eventually die anyway. So let's make sure he dies comfortably. And how you do that is you administer 10 milligrams of midazolam, 10 milligrams of morphine subcut. So that takes the pain away, it takes the anxiety away, and he dies comfortably. Typically, when I was working in palliative care, I used to write on the medical charts, on the charts just before I left at 5. I used to say, if this patient has a catastrophic bleed, please administer midazolam subcut or morphine subcut 10 milligrams each, and I walk away, because that way the nurses who are there throughout the whole day can administer those medications even if I'm not there. And that's what's typically done. All right, so forget about the rest of the things like IV fluids, blood transfusions, because blood transfusions aren't even available in the hospice. You need to get someone to go all the way to the hospital to bring a bag of blood back to the hospice. Sure, yes, of course, the hospice will have IV fluids, but you're not going to benefit him by giving him IV fluids. you might prolong his life for a couple of hours. And so what you've done now is just prolong his distress for a few more hours. All right. Other things are not suitable as well. In this case would be IM epinephrine. You don't do that. Terlipressin, group and safe, blood transfusions, vitamin K, fresh frozen plasma. All these things will not be your answer in the exam because these things are not done to in palliative care. Right? Remember the goal. We are not here to prolong life. We are here not to shorten life, but we are here to make you comfortable towards the end of life. Of course, if this is a young man, this is a 21-year-old man, no cancer, do your best to save his life. But if he's already bedridden, not even able to get up for the last 3 months, he's not able to talk, what are you doing by trying to save him a couple more hours? So, moving on to the next question.
Buttock rashes. Yeah, buttock rashes are the classic in the Plab exam. When you see a buttock rash, you need to think of a number of different diagnoses, such as Henoch-Schönlein purpura, such as the condition suggested here, such as psoriasis. There's lots of things you need to think of, but it is a bit of a clincher when you have a buttock rash. Yeah, so what you should be telling me is the diagnosis and then how are you going to confirm it? So lots of answers here coming, and actually quite a few, a variety of answers coming through. So itchy vesicular rash on the buttocks. This is dermatitis hepatiformis, isn't it? This is the cutaneous version of celiac disease, yeah? This person has no gastric symptoms. And so the way to diagnose it is actually doing a skin biopsy. So the answer is D, perform a skin biopsy to confirm the diagnosis of dermatitis hepatiformis, which is the cutaneous form of celiac disease. Now, we all know that you treat celiac disease with a gluten-free diet, and that's completely appropriate in this case, but it is a very distressing condition, significant itching with associated morbidity. And so you can offer a certain medication to treat dermatitis hepatiformis. Does anyone know how you can treat it? Absolutely, someone got in there straight away. Dapsone. Now it is associated with agranulocytosis, so it is. You have to be aware that it isn't a completely benign drug. But yes, if you're asked in the exam how are you going to manage dermatitis hepatiformis, dapsone would be the appropriate answer. Next slide. So I'm feeling that celiac disease comes up in the Plab exam. It's always worth 3 marks by far, knowing that it's an autoimmune gluten enteropathy associated with wheat, rye, and barley. Everything else, forget about it, right? Most people seem to be aware of the NICE guidelines recommending using anti-tissue transglutamase antibodies, yeah? And it is the specific IgG form of the antibodies, the anti-tissue transglutamase IgG antibodies. But at the same time, yeah, actually the antibody that you're looking for is IgA, sorry. But at the same time, you need to be checking IgA levels because IgA deficiency is another autoimmune condition which can be prevalent with celiac disease. So what you do is you check IgA tissue transglutamase antibodies, sorry I got that mistaken, and IgA tissue transglutamase antibodies and IgA immunoglobulin levels, because if you have a deficiency in IgA immunoglobulin, so you're not producing it, then of course you're going to be negative for IgA tissue transglutamase antibodies. So therefore, what you do is you do an IgG form if you are deficient in IgA immunoglobulin. Now let me say that again, just because I probably confused you more. The initial test is IgA tissue transglutamase antibodies. At the same time, you're checking IgA levels as a whole. And if that person does not produce IgA immunoglobulin, then actually, of course, your IgA tissue transglutamase antibodies will be negative. But that's likely to be a false negative. And therefore, checking the IgG form of tissue transglutamase antibodies in the context of IgA deficiency is important. Once you have positive serology, then you do a duodenal biopsy. Now, I've seen terrible questions written in the Plab exam about asking you where to do the biopsy, the duodenal or the jejunal biopsy. And actually, the guidelines suggest you can do both. But if you're asked to choose between one or the other, then duodenal is the most appropriate. Next slide. And this is your hepatiformis dermatitis hepatiformis, an itchy vesicular rash, usually on the buttocks as a clincher. Yeah, you confirm through skin biopsy and the gluten-free diet with dapsone as the treatment. Next slide.
Lovely. So 1 more minute, guys, for you to answer this one.
So as the obstetrician of the group, I allow Z to answer this question just to keep his knowledge up just a little bit. You know, he's too busy with his Plabable gems and all that kind of stuff. We need to keep him involved in obstetrics. So I see it as a bit of public service that I allow him to.
Now, guys, at one point of time, Adam was actually my junior in obstetrics and gynecology. At one point of time. Before I left obstetrics, of course.
But he was disgraced. He was
I had to teach him how to do a C-section, guys. That was hilarious. He fainted. No, I'm kidding. But anyway, your answer here is a CTG. Now, when I did the Plab exam in 2016, I remember seeing, I was talking to a lot of my colleagues and they were like, oh yeah, we will do an ultrasound here. And these are people who are sitting for the Plab exam, of course. They're not obstetricians, but they're just people like, you guys. And they were like, oh, of course we do an ultrasound. We want to find out if this is placenta previa or placenta abruption. And I was thinking, oh my God, that's definitely wrong. No one would ever do an ultrasound in real life because this patient has pain, has vaginal bleeding, has reduced fetal movements. Now, you need to check if the fetus is okay or not. Because if this patient has fetal distress, your next step is to do a C-section. Forget the ultrasound because the ultrasound is not going to tell you much of anything. Sometimes an ultrasound can see retroplacenta, hemorrhage, and yes, that could help you lean towards a placenta abruption. But ultimately, placenta abruption is a clinical diagnosis. You don't need to use an ultrasound to diagnose this. But you need to do a CTG to know if you need to take the baby out right away. So that's why you're doing a CTG as the next best step. So things to remember for placenta abruption. The abdominal pain is constant. But if you feel the womb, it's going to feel like wood, all right? It's woody hard. It's very, very, very hard. Bleeding may or may not be present because sometimes the bleeding is concealed, right? And then fetal distress is something you look out for. If the mom's bleeding a lot, obviously she'll have some form of hypovolemic shock. Now, the things I really want to point out to you guys, and I really highlighted this here, is remember that vasa previa and placenta previa are usually painless bleeds. And this is important for the exam because if you see painful bleeds, then automatically you're going to be leaning away for placenta abruption as the answer. All right. And lastly, the next point I want to bring up with you guys is that fetal tachycardia and fetal bradycardia are considered fetal distress. All right. If your CTG shows a baseline fetal tachycardia of 180, you don't say, oh, it's not fetal distress because it's tachycardia rather than bradycardia. No such thing. Bradycardia or tachycardia, they're both considered fetal distress. Now, just to recap, because someone's asking here about the other options, and I want to run through the other options with you. Now, a clotting screen, obviously, I don't think anyone's going to do that because, it's not going to benefit this woman here. A group and save, some people might say, oh, that's a good option because you want to make sure you have blood available to transfuse the woman, right? And yes, in reality, that is a good idea to do. Not the best thing to do, a good idea to do. But even if you didn't do this, it's not the end of the world because all maternity units in the UK would have O negative blood in the maternity ward. This means that they can easily come and transfuse the woman who's been bleeding, of which you don't know what her blood type is. So group and save, good idea, not completely essential. And a Clerical test, that is something not done in an emergency scenario. A Clerical test is a blood test used to measure the amount of fetal hemoglobin transferred from a fetus to the mother's bloodstream. It's used to determine the required dose of rhesus immunoglobulins to prevent rhesus de-isoimmunization, all right? So basically, in a nutshell, it is a test to determine how much rhesus immunoglobulins to give the mom in order for her not to form rhesus antibodies, which could later on affect her positive rhesus children. I hope that's clear, guys. So ultrasound, no point doing, all right, because obviously it's a clinical diagnosis. Good. Now, Adam, since now you are a super obstetric lead here, anything you would add on to this?
No, I think you did very well. The gold star for you. You can keep your t-shirt. I'm very pleased, man.
Amazing. Good. So the next one here.
Good. So keeping in the obstetric kind of style, one that Plab candidates really struggle with is postpartum mood disorders. So people seem quite consistent with this, which is good. So let's go through it. So the first thing is you clearly have an idea that this is postpartum mood disorder question. And the first thing you should look at is how long ago did she deliver her baby? Yeah, saying 4 weeks actually gives you an idea that it's likely not to be baby blues and it's looking more like depression. She's crying all the time, not bonding with the baby, very anxious, not sleeping, and thinks she's a bad mother. You're looking for basically signs of depression. So anhedonia, poor sleep, low mood. And the answer here is postpartum depression. And my next slide shows you a summary of what the different mood disorders are. So Z, so remember, baby blues, that's up to 2 weeks. And it's really just about supporting a new mother through a change in life circumstance, a huge hormonal shift. And I don't know who has children here, but Z went through baby blues when he had his baby. He had his baby blues. He was like, you know, maybe Plab isn't the right exam for me. Maybe I should be doing more A-levels and OLETs. But no, the key thing is you just need to support him. I gave him a little hug. The key thing is support, 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 because a new baby is absolutely a mega life change. Depression, on the other hand, is, as I said, you get signs and symptoms of depression: low mood, anhedonia, poor sleep, irritability, and you may want to even harm yourself or your baby. Yeah, it usually happens about 4 to 6 weeks after delivery. Yeah, but you don't have delusions or hallucinations. Yeah. So usually if you want to harm your baby, it's the fact that I just can't look after my baby. I think the baby would be better off with somebody else or not alive. Psychosis happens anytime, but usually happens in the first couple of days. And that's where you have your hallucinations and your delusions, completely unshakable beliefs. So my baby has evil eyes, my baby is Hitler, my baby is sitting the Plab exam, my baby is Z, my baby is a Smurf, my baby, you got to keep going. I could just keep explaining that actually psychosis is a delusional belief regarding usually about the baby or themselves. So the baby's not mine. All those things are delusions. Yeah. So baby blues is support, support, support. Depression, if it's mild, we can use cognitive behavioral therapy. If it is severe, moderate, then we're going to use an SSRI like sertraline. And psychosis is going to be, in the Plab exam, ECT. Yeah, you can use antipsychotics, but the indication for ECT is usually that the mother or baby are at risk. And in the Plab exam, the clincher will be that, you know, she thinks the baby has evil eyes, or thinks the baby is cheating in the Plab exam and wants the baby gone. And so it's important to look for delusions, hallucinations, and remember psychosis occurs in the first couple of days usually. Yeah. But you can't say wanting to harm the baby is one or the other. It depends if there's a delusion there to do it. Okay. Now, next. Unfortunately, this is a completely different Adam. It's nothing to do with me. It's just Z trying to get his own back.
Amazing. All right, so I'm going to reveal the answer here. And your answer is you're going to report to the lead consultant. All right. So now a lot of people are asking, what is patient advice and liaison service? This is also known as PALS, P-A-L-S. You know, everyone knows what PALS is when you come to the UK. The reason we know what PALS is because that is a service for when patients want to complain about the NHS. So let's say, I'll give you an example. Let's say Adam's really bad in his job, right? He shouts at the patient and the patient's really unhappy. Patient will make an official complaint through PALS. They will try and find how, you know, PALS would advise them on how to make a formal complaint. And PALS doesn't just do complaints, but they hear patients out. They hear if they can improve the service more in the hospital. They try and do those kind of things. All right. So PALS here is unfortunately not appropriate because no one's trying to complain here. No patients are going to complain here. All right. The only person that's going to complain is the doctors because it's not professional. All right. Now, the reason why you're reporting to the lead consultant instead of reminding him that his actions are not in line with good medical practice is because you have already done that. You've already challenged Adam and you've already told him it is inappropriate, and he's defended himself, saying, I think it's fine. She's attractive. Why not? Right? So you're not going to tell him again. You're going to report this to the lead consultant. Now, lessons to be learned here. All right. The first lesson is Adam is wrong. All right. Put that in your brain. Adam is wrong. Okay. Now, the second thing to remember is it is inappropriate to start a relationship with a former patient that the professional relationship ended recently. All right. I want you to memorize that phrase, right? Because that's really important to know going into the exam. Now, I'm going to give you another example here. How many of you guys watch The Good Doctor? All right. So in season 1, episode 17, all right, you have Dr. Kalu, who has fallen in love with one of his patients. And I don't know her name, but I remember her as the tilapia scales lady. All right. And then what happens next is he then says, you know what? I have asked Dr. Murphy to be your doctor, so I am no longer your doctor. Now I can go out with you. Is that right? Is that ethically correct? Was that correct? The answer is no. Okay, it's entirely inappropriate because he just treated her. Even if he's no longer her doctor, her doctor is still inappropriate. So, top tips to remember, to take home and to remember this. Patient who asks you out on Facebook, answer is going to be no. Former patient of which you are no longer treating, you're not to go out with her. No, no, no. If it's an attractive former patient of which you are no longer treating, the answer is still no. All right, guys? Attractive doesn't change anything.
But if she's ugly, it's totally fine, okay? So if she is not attractive, you can date as soon as you discharge her, okay? As soon as you do that, just jump in. Sorry.
and then lastly, the only situation where it could be a maybe is if you've met the patient that you've treated 30 years later, all right, in a party, and you remember her as a patient, but this is like 30 years ago, then perhaps yes, all right? There isn't a specific time limit, but if you go through the GMC guidance, they specifically say, a former patient that the professional relationship ended recently. Into how many years that is, I don't know. But I would say 30 years are probably quite okay. Now, next question.
Okay, so now it's about not only about emergency contraception, but about looking for red flags. So we've seen a big shift in the Plab exam where a lot of candidates are now becoming familiar with this type of question because there's no reason that you should be getting these questions wrong now. These are straightforward, follow a clear pattern, and it's just following the certain rules associated with it. So remember that the age of consensual sex in the UK is 16. So over the age of 16, you can pretty much have sex with anybody you want, so it doesn't matter the age or anything like that. If you're over the age of 16, it doesn't become a child protection thing anymore, because in the eyes of the law, it's not a problem. That does still indicate that there can be some ethically challenging scenarios, but none that are likely to come up in the Plab exam. Between the ages of 14 and 16, you need to show that there is evidence that this patient is Gillick competent, and that there are no red flags. And if you read this, you very quickly find that there's a red flag: having sex with their teacher, somebody who's in a position of trust, So the answer here is contact your local safeguarding officer. You very, very seldomly will choose contact the police in the Plab exam at all. And so the answer is E here. Z, wake up. Next question. Next thing. So remember that if at all the question is about a girl or boy under the age of 13 having sex, it's always a criminal offence. You always quickly refer to Child Protection Services ASAP, who will then take action to either put that child in a place of safety and contact the police through the correct channels. We've already talked about that you must be 16 or over to have sex, and honestly, it doesn't matter who they have sex with. That's not your issue in the Plab exam. Under the age of 16, so between 14 and 16, look out for signs that there's a red flag. So they're having sex with either somebody in a position of trust, a teacher, a doctor, a carer, or somebody who's significantly older than them. And in the Plab exam, it's very difficult to define what is significantly older, but my advice is that it's over the age of 10 years, and they'll make it very clear. Yeah. Next slide. Now, before we go on to talk about a little bit more questions, it is important to know about our other services that Plabable offer. Our most popular resource is the 4 days of Adam and Sze revision course. That comes with our new October Big Mock. Remember, we write a new Big Mock of 180 questions per revision course. And actually, what you find in this course is you find out the reason why Sze left obstetrics. I'm not going to give any clues there, but you find out the age-old question of why Sze left obstetrics. We go through a number of important topics. We bring guest speakers. So the next slide will show that we've got Hannah, who is an amazing acute medicine registrar. She's been going for a long time, very intelligent. And Zin, our master of neurology, because that's the stuff that people struggle with, isn't it? The neurology locations of the brain, the neuroanatomy, really challenging. So we highly recommend joining our 4-day course. It is good fun as well. It's a good laugh. And it's good use of your time. We also have a specific pediatric revision webinar, because at the end of the day, you need more time learning the milestones, the vaccinations, the different respiratory conditions. And so we've made a specific 2-hour webinar just for that. Yeah. Then on the next day, we've got Sze teaching the hardest questions. This is a very popular one because maybe people are too confident, they need to be knocked down a peg or two. So Sze talks about some of the most challenging questions in the Plab exam and talks about how to approach them in his special ways.
Absolutely.
Those who struggle to understand ECG, well, not only do I have an ECG interpretation masterclass, I throw in an ECG quiz at the end of it as well, because you need to know your supraventricular tachycardias from your atrial fibrillation, from your atrial flutter. You need to know how to manage ventricular fibrillation, ventricular tachycardia, torsades de pointes, and you need to know what on earth is the difference between synchronized and unsynchronized DC shocking, and all the medications thrown in there as well. So I've put on a 2-hour webinar for you there. The next slide shows also the very popular Obs and Gyne Webinar, which, do not worry guys, I teach it, Sze doesn't, I keep him away from it. But that's the stuff where you're like, what on earth is going on with the swabs? Nobody can get their head around the swabs. Do not worry, I make it clear. Contraception, fibroids, infections, ectopics, miscarriage, pregnancy, I throw it all there in 2 hours because I can take my time and go through it in depth. And then I think the big beauty, my favorite webinar, it's where just before the exam, you come and join me for 2 hours. I go through what I feel is the most essential stuff for the exam, what I give you my predictions about what is going to come up in the exam. And it's just a bit something different because you're so sick of doing doing book work or revising at home. Come join me for a 2-hour webinar. We'll have a chat. We'll get to the point of the most common errors, pitfalls, and essential knowledge. Bring the information in your brain to the front so that you are ready. Yeah. And
there's one more, Adam.
And sometimes we haven't got a date for the ethics and law webinar, but we try to run it as number amount of times as we can. All the timings are on the Plabable website.
Amazing. And lastly, guys, just in regards to the question bank, I'm sure you guys all have a subscription already because that's probably how you heard of us. Now, I just want to put up one important key point for everyone to remember is don't just memorize the answers, read the explanations. What we find is everyone's trying to memorize just the answers without going through the explanations. And these are the people that fail. All right. Of course, it's bad luck. Plus, they're not reading explanations. All right. Of course, if they had good luck, then they probably pass. But my point is, explanations are really important, and we take a lot of time to draft it up. So look at that, memorize that, not just the answers. We are here not for you to just go into the exam and vomit out everything. We want to make sure that you guys are better doctors at the end of the day. All right. So when you guys come into the UK, you guys are practicing medicine the Adam and Sze way. All right, good. So there are still some bonus questions, guys.
Of course, we're not done yet. We just thought we'd have a little chat, you know. We've got other services, we want to tell you about them. So, I'll allow Sze to do this one because he likes talking about babies. So
I love this one, absolutely. So I'm gonna give you guys a minute to answer this. All right, so amazing, guys. A lot of you got that right. Some of you got it wrong, and I'll explain what you need to look out for here. So a mother delivered a term baby 9 days ago. Look at the time frame, 9 days ago. Blistering rash. So, okay, you know she's got a blistering rash. What do? You can advise her to continue regular well baby care for the infant. Now, how do you know what to do? You look at the guidelines provided by Public Health England, which tells us that if the onset of rash is beyond 7 days or before 7 days from delivery, then you need to provide varicella zoster immunoglobulins. All right. Sorry. Then you don't need to prescribe varicella zoster immunoglobulins. All right. If it's between 7 days from birth or 7 days before birth, and then the mom has a rash, those are the people that you give varicella zoster immunoglobulins. Does that make sense? All right. So anyone between this time and this time, give them varicella zoster immunoglobulins. Sure, a lot of people would argue back and say, you know what? I've read Oxford Handbook of Clinical Specialty, the 10th edition, page 144, and that's told me no. Sze, you're wrong because, the mom needs to have, the babies need to have varicella zoster immunoglobulins if the mom has chicken pox up to 4 weeks, not 7 days, but 4 weeks. And yeah, you can say, yeah, Oxford handbooks are great, but they are not guidelines, guys. So don't fully look at Oxford handbooks because they're written, but they are out of date very quickly. And our whole practice is based on guidelines rather than Oxford handbooks, right? No one in court is going to defend you if you follow an Oxford handbook and forgotten the guidelines, which is what we are supposed to be following in the UK. All right, so
I completely agree with that. Yeah, it's all about that's why we run the courses and webinars, because we put up-to-date guidelines, up-to-date advice, because it's hard to keep up, but the Oxford handbook is out of date as soon as it hits the shelves.
Absolutely. And so I've thought about how did this Public Health of England come up with this 7-day rule, right? So I've come up with my own theory of evolution from V to 7. I suspect what they did is they just taken that V for varicella exposure, all right? And then they just slanted it and moved it all the way and made it look like a 7. And that's how the 7 rule has come about, right? So 7 days before, 7 days after, any time between that is when you want to give IV immunoglobulins. Good. Oops. I hope I didn't reveal the answer to that, Adam. But this one's yours.
Okay, so hyperemesis. Such a nice one because there's so many kind of questions and questionable stuff and mode of action and all of that. So I'm sure Z completely ruined it for you by revealing the answer. And all he has to do on the webinar is click a mouse, and he isn't able to do it, and it's so upsetting. He has one job. So useless. So I'm really sorry about Z, but the key thing is that you need to know your first line, your second line, your third line approach to the management of nausea and vomiting in pregnancy. So you start off with cyclazine, so that's your antihistamine with your prochlorperazine. That is your first line. But this person has already had that. So then you go to your second line. And your second line is metoclopramide or ondansetron. Now, metoclopramide would usually be the correct answer here. However, it's relatively contraindicated in those under the age of 18 because you can develop acute dystonic reactions, such as torticollis, acute oculogyric crisis, pseudo-Parkinsonism. And so in this patient, you would offer ondansetron. Third line is steroids, but it's unlikely that it's going to come to that in the Plab exam. Yeah, so metoclopramide, which is your dopamine antagonist, would be your usual one if she wasn't under the age of 18. And remember, to treat acute dystonic reactions is you can use IV procyclidine. Yeah, so IV fluid's always a crystalloid, always with potassium. There's the antiemetics. And don't forget thiamine, because if you're vomiting, and absolutely not being able to meet your nutritional needs, you could actually develop Wernicke's encephalopathy in pregnancy. Folic acid, a 5 milligram tablet rather than a 400 micrograms. And that's because the first trimester, when the vomiting is happening, is the highest risk for neural tube defects. And so it's so essential that you give them a high dose of folic acid. And don't forget, these people are prothrombotic. You have a 4 times increased risk of a venous thromboembolism in pregnancy compared to outside of pregnancy. So some patients with additional risks may need low molecular weight heparin, or if they're admitted.
Amazing. So this is, I believe, the last question. Fantastic, guys. So your answer is indeed arrange a meeting to discuss the patient's best interests. Now, I know a lot of you guys would have picked apply to court for an independent ruling, but that's not the answer here. And I'll tell you why. So first thing is that you need to realize that this patient has a learning disability, right? She is lacking capacity. and she's not compliant with her medications. And because of that, she's anemic, right? So what a meeting consists of is healthcare professionals alongside the family members to try and decide what is the patient's best interest. Is the patient's best interest to take those tablets and feel better, or not to take those tablets and feel anemic? So that's the first thing, right? Because while I might think it's the patient's best interest, I think we need to get a whole group of us to agree that that is the case. And that's why we need a few doctors, the family members, her close friends, everyone that can come together and decide for her. All right. If you fail to make a decision based on that, then we try to get an independent advocate. So an independent advocate is someone that comes in independently from the healthcare providers, and they look at the patient, and they are basically the voice of the patient. So they listen to the patient and say, I'm going to try to talk on your behalf. But of course, I'm going to consider the impact that not taking these medications has on yourself. So they try to be unbiased in any form, all right? And usually once you involve an independent advocate, then it's clear, the decision becomes clearer, everyone agrees to that, and consensus is reached. We go along with that plan of action. If you fail, if you don't reach consensus, if you don't reach a general plan that everybody agrees on, then your next step is to involve the court for independent ruling, because you don't know who's right, who's wrong. What are we going to do? We need to move a step higher and involve the court. All right. Now, in my experience, I have done a lot of this where it comes to arrange meetings, gone down to the independent advocates as well, but never to a court. It's so rare that you reach a court. All right. So that is all from us. Now, we are so happy that you guys have joined. Now, of course, we understand that we haven't been answering a lot of questions, and that's because we've got several hundred of you joining, and it's so hard to keep up with the questions. But for the courses, it's more quiet, so we can definitely focus on your questions, and we give time in the courses after our lectures to address your questions. Of course, today we don't have that time. We can address a couple of questions, but not all of them.
This is just a sample of what we can achieve.
Absolutely.
Yeah, because the problem with ethics particularly, you're like, well, what if they're 13? What if they're 13.5? What if they're 14 years old? What if the teacher has recently retired and then having sex with her? So obviously we cannot give that attention really, yeah.
Absolutely. So guys, now that is everything from us. Is there any questions that you want to take on, Adam, before we head off?
No, I think we've covered most things. And as I say, we can't just answer every single ethics question. So the key thing is good luck, guys. Just a small sample, as I say, our webinars and courses are much longer and more interactive. Good luck. Really great to show our faces to you and show off our new t-shirts.
Yes.
And good luck regardless of whether you join us in anything or not. Yeah. Goodbye. We are going to sign off now.
All right, guys. Bye.